So TRITON3 was a randomized phase 3 clinical trial, a registrational trial comparing Rucaparib to physician's choice of standard therapy for patients with metastatic CRPC whose disease harbored alterations in either BRCA1, BRCA2, or ATM. Importantly, in this design, the standard of care included 3 options. It was docetaxel, abiraterone, or enzalutamide. And it was in patients who received at least one androgen receptor pathway inhibitor in the past, but who had not had chemotherapy in the castration-resistant setting. So this is moving Rucaparib to an earlier line to the pre-chemotherapy space for CRPC, and importantly, going head-to-head against docetaxel and the oral agents as standard of care. So, really a rigorously designed study meant to answer, the key question of is a PARP inhibitor, is Rucaparib in this space better than standard of care? Correct. So the current approval for Rucaparib is for use in BRCA mutant metastatic prostate cancer in patients who've already had chemotherapy and an androgen receptor pathway inhibitor. So that's a later line of therapy. It's really post-docetaxel, post-chemotherapy. And the point of TRITON3 then was the definitive study to position Rucaparib earlier in therapy prior to chemotherapy. Yeah, and recognizing that with any malignancy, certainly prostate cancer, disease evolves over time, right? And it's not a given that a drug is equivalent in different lines of therapy, right? We really have to demonstrate that, number one. Number two, the accelerated approval that Rucaparib is currently prescribed under, was based upon single-arm phase 2 data, based upon objective response rate. But we still needed the definitive randomized phase 3 clinical data, right? The comparative data to say how much is Rucaparib better than existing therapies. Is it truly? We had to prove that point, and of course we have now that we have this positive study. Definitively, Rucaparib is better than standard of care therapy in this patient population. So the study was powered for radiographic progression-free survival, and Rucaparib led to a 50% reduction in progression or death compared to standard of care therapy. So the standard of care, as I said, patients, about 55% received docetaxel, about 45% received either abiraterone or enzalutamide, and the benefit in RPFS was it was median RPFS of over 11 months in the Rucaparib-treated patients, and only 6 months in the standard of care treated patients. So really a meaningful difference there, clinically meaningful and statistically meaningful difference. Yeah, I would certainly think so. I think that's the reaction we heard from the audience, right? And the conversations after the presentation and the questions and the reaction amongst the community after the fact. When you think about all of our mCRPC studies, most drugs are leading to an improvement in survival on the order of 4 months or so. Remember that in this population, OS is 2.5, 3 years, something like that, right? So when you start talking about adding 5, 6 months plus, that's meaningful, certainly. Now, it's not a cure, right? We absolutely want a cure. To the point of your question, perhaps, is we'd love to wipe out the disease and cure. We're not there yet. In the meantime, we're going to take these, steps forward and these incremental improvements because they certainly add up. And you look at what we've done over the past decade in prostate cancer, it's been a series of incremental improvements. And with those incremental improvements, we've gone from median survivals of 3 years to 5, from the time of metastatic disease. So it absolutely matters.